Jonathan Sterne from here in Bristol, who is going to discuss the iterative process of specifying, emulating, and target trial.
Yep. Thank you very much for the invitation. This is joint work with the people listed here, and I particularly want to acknowledge Kate Gurney sitting over there, and Sarah Sterwalla from the University of Cambridge for their help in putting slides together. And I've got a point there, haven't I? Or maybe I've got to go forward. So I'm going to describe using two examples the iterative process of specifying and emulating a target trial. The two examples are treatment strategies for erythropoietin or EPO therapy for treating anemia in hemodialysis patients, and addressing the question of whether we should escalate disease-modifying therapy after silent lesions in patients with relapsing, remitting multiple sclerosis. And I hope to generate some discussion on the implications for protocols and open science practices when we emulate target trials. So the first example, and probably the longer example, is this work led by Kate Burney on comparing treatment strategies for EPO therapy. I've said all that. So this is all about anemia or low hemoglobin, which is common in patients with chronic kidney disease. So low levels of hemoglobin, abbreviated to HB, indicates anemia, which can also be measured by hematocrit. Symptoms are found and include reduced quality of life, fatigue, decreased exercise capacity, shortness of breath, and anemia is associated with an increased risk of morbidity and mortality. It can be treated using erythropoiesis stimulating agents, abbreviated in many of the slides to ESAs, together with iron supplementation. And these reduce the risk or the need for blood transfusions, which are the only other way to treat anemia. So there's absolutely no doubt that these ESAs increase hemoglobin, and there's absolutely no doubt that being anemic is associated with morbidity and mortality. Even partial treatment of anemia with ESAs is expensive, and full correction of hemoglobin to normal levels requires high doses. When these drugs were first introduced into clinical practices, there were no randomized trials because they were thought unnecessary and even unethical. But the question of whether full correction of anemia is preferable to partial correction has now been tested in several randomized trials of patients with chronic kidney disease. And so these are sufficiently high-profile trials that they were all published in the New England Journal of Medicine, the QUIET trial in 2006, the CREATE trial in also 2006, and the TREAT trial in 2009. And without spending a load of time on the details, they were targeting higher versus lower hemoglobin, and unexpectedly found that 2 of the 3 trials found adverse effects. So you can see that the QUIET trial found a hazard ratio comparing high risk with low risk patients of 1.34. And the TREAT trial found that the hazard ratio for stroke was nearly doubled in patients with the higher versus lower hemoglobin target. So now, important to understand that low versus higher hemoglobin implies lower versus higher doses of the drug. So this is a figure from the QUIET trial showing that the doses were much higher in the high hemoglobin group than the low hemoglobin group. So this all led to evolution of the guidelines towards more conservative targets for hemoglobin. Originally, the Renal Association guidelines were for hemoglobin more than 100 grams per litre with no maximum. Then these trials were published and the guidelines became more conservative, for example, 105 to 125 grams. And the TREAT trial was published and the guidelines became still more conservative, 100 to 120 grams. And then then guidelines said that these drugs shouldn't be used to maintain hemoglobin above 115. So the results of the trials were that treatment became more conservative and people stopped trying to target restoring hemoglobin to the levels that you would see in a patient without chronic kidney disease. And so you can see that over time, hemoglobin levels in patients so hemodialysis patients are patients who need renal replacement therapy and who are often waiting for kidney transplants. And in these patients, hemoglobin levels declined over time and dosing declined over time in response to the randomized trials. And the percentage of patients who were on these drugs also declined over time as the trials were published, suggesting these adverse effects. So the motivation for this work was that treatment guidelines might prevent patients without major comorbidity from receiving the maximum benefit from treatments. There weren't new randomized trials weren't planned, so we wanted to look at the effect of different dosing strategies on mortality of patients undergoing hemodialysis. Data were from the UK Renal Registry, which collects clinical and biochemical data from all patients aged at least 18 years receiving renal replacement therapy in the UK. Data received in 62 hospitals, extracted electronically on a quarterly basis. And typically, the last value of quarter is used for different measures. Some hospitals submit data extracts that include ESA doses, and we extracted those. We restricted analyses to those doses and to patients on a particular drug, darbepoetin. Now, as one of the rules of this field generally, and of my work specifically, is that Miguel Hernan always gets there first. And back in 2008, he had published a paper on the effect of the poetin dose on hematocrit, measure of anemia, with the aim of mimicking a randomized trial. And then they published this paper on the estimated effects of EPO dosage on survival in elderly hemodialysis patients. This was looking at the effects of cumulative average doses. And this paper saying high doses of poetin don't lower mortality and cardiovascular risk. So we spent some time wondering whether this was all a bit of a waste of time. But then I think when we talked to Miguel, he said that this particular paper is one he used in his teaching as an example of inappropriate target trial emulation, because the question is not about dosing, it's about dosing strategies. So we're not, clinicians are dosing in response to hemoglobin levels. They're never going to just give people a high dose regardless. The doses are, these are dynamic strategies where the dose is in response to, the dose reduces when hemoglobin levels go up and increase when hemoglobin levels go down. So, which is what it says here. Strategies are dynamic. Weekly dose depends on hemoglobin, which in turn depends on prior weekly doses. So, and here's so we ended up restricting to centres that could provide daily data. And here's an example of a patient with daily data where the hemoglobin starts low here, the dose is 20. After it hasn't gone up for a while, the dose is increased to 30. It does go up, and then the dose is decreased again, and then decreased again to 15. It then goes down again, and the dose goes back up. So this is just appropriate clinical practice where you're trying to give people only the dose they need to raise their hemoglobin. It took, this is familiar in the field, but it took 3 years to acquire, more than 3 years to acquire usable daily data from 11 centres around the UK. So this was our first attempt to define a target trial of dynamic strategies. The eligible people were aged at least 18 years who'd been on hemodialysis for at least 3 months and were on ESAs. There was an exclusion criteria, and we wanted to compare restrictive with liberal, with a restrictive with a liberal dosing strategy, primary outcomes, all-cause mortality, and follow up with from eligibility until death or recovery or withdrawal or transplant. So the idea was that we would compare a liberal dosing strategy in which doses of up to 150 micrograms per week were permitted, with a restricted dosing strategy limiting doses to 50 micrograms per week, and that where patients would change to the next dose upwards or downwards to keep hemoglobin in a target range. And that idea failed. And this is where emulating target trials gets iterative. Firstly, because patients were rapidly censored. So there were simply not enough patients who were adherent to either of these strategies over time. And also because patients who died while being followed up in the restricted group also had follow-up consistent with the liberal group. So there was insufficient separation between follow-up in the two strategies. But Kate was undaunted, the group was undaunted, and we went to attempt 2, which is the one that I'm going to spend most time on. And in this one, we designed dosing strategies consistent with an upper or a lower hemoglobin target. So the lower hemoglobin target is 95 to 115. One of these is the upper target. The more aggressive target is 105 to 125. And we designed a strategy corresponding to what we would like to see in a randomized trial, where dosing decisions were based on current hemoglobin, previous hemoglobin, and previous dose changes. And doses were allowed up to 150 micrograms per week. And after extensive discussions with our clinical colleagues, we came up with this. I'm not going to spend loads of time on it, but this idea of if you've got a target range, if hemoglobin is below the target, we ask, was the dose increase last month? If yes, we do one set of things. If no, we increase the dose. And similarly, if the dose is above the upper range of the upper target of the range, we ask, was it decreased last month? And if no, we decrease the dose, and if yes, we look at how much it was lowered. And then we came up with this table listing the acceptable dosing changes corresponding to where you are at the moment. All of this took a very long time. We then adjusted things based on limitations in the data. So if no blood test results for a patient since the last month, we kept the patient eligible this month while waiting for the blood test to be ordered. And we allowed a grace period for 1 month, for example, on occasions where doses should have been changed but were not, because to see if the hemoglobin settled. Again, trying to mirror what was seen both in the data and what our colleagues told us was standard clinical practice. Now, those of you who have been keeping up will have recognized these as examples where the two treatment strategies are not distinguishable at the beginning of follow-up. And if you follow the super useful flow chart in this paper by Fu and colleagues in the BMJ last year, or was it this year? I think last year, you'll know that when treatment strategies are not distinguishable at the beginning of follow-up, then we need to clone and use clone sensor IP weights. So that's what the flowchart tells us. And here's Miguel's paper from 2018 describing clone sensor IP weights. So for those of you, I'm sure you're all familiar with this, but for those of you who aren't or who have forgotten, you take each patient's data, you copy their data, and you assign one copy of the data to each strategy, and then you censor follow-up when the patient deviates from the strategy that you assign to that copy of their data. And then The censoring is going to be informative, so we use IP weighting to adjust for the informative censoring based on pooled logistic regression models for the probability of being censored over time. The literature is really quite silent on how to organize data in order to do this. We need to use pooled logistic regression, so we need to discretize time into regular intervals. And in principle, you'll be familiar with the idea that we've got the confounders at the start of the interval, whether the treatment occurred during the interval, and whether the outcome occurred in the next interval. But in practice, our data are much messier than that. We need to have rules for what we're going to do when we get multiple measures of treatment and confounders in the same interval. So here's an example where we're imposing regular intervals, and we've got to have rules for what happens if there's a hemoglobin measure either before or after the dose change within the interval. So that we're in the process with colleagues from Causal lab of writing a paper on the rules for step 0 of target trial emulation, which is about discretizing time. So 8,131 patients met eligibility criteria included. For the lower hemoglobin strategy, after censoring, there were 355 deaths in 38,000 patient months. In the highest hemoglobin strategy, 303 deaths in 37,400 patient months. That's an unweighted hazard ratio before all the IP weighting of 0.87. So these three panels show darbepoetin dosing, and I meant to check this with you, Kate, but you'll see that darbepoetin dosing is both right skewed and non-continuous, and that turned out to be because the doses are all dependent on fixed amounts in pre-filled syringes. And I can't remember exactly how it works, but you can end up with doses as low as 2.5 grams and as high as 150 grams in each dose, but in these discrete intervals. You can see that the probability of receiving the drug at all goes up with previous hemoglobin level, and the dosing is inversely related to previous hemoglobin level. So we, as you can imagine, thought carefully about candidate predictors of treatment and fitted models for treatment over time. I should say, of course, that here treatment is censoring. So to get a model for the probability of being censored, we need a model for the probability of being treated, and then we need to work out your probability of receiving a treatment that doesn't correspond to the assigned treatment strategy. Now, this turned out to be very difficult in this context because you've got two components to treatment. You've got being on or off treatment, and you've also got the size of the dose if you are on treatment. So we fitted logistic regressions for being on 0 dose, separate logistic regressions for going off the drugs if you're currently on them, and for staying off the drugs if you're currently off them. And then a heteroscedastic linear regression for log dose, conditional on being on the drugs. So the probability of adhering to strategy day to the assigned strategy depends on whether a 0 dose is permissible given your current dose and hemoglobin. If it is, then it's the probability of receiving a 0 dose given your covariate and treatment history, plus the probability of receiving an acceptable dose within the range here based on this heteroscedastic regression. And then if a 0 dose isn't acceptable, it's the probability of being within an acceptable range given your covariate and treatment histories. At this point, we looked at the weights and we found we had a problem of very, very large weights corresponding to the small doses, and realized that although the heteroscedastic regression was working for most of the doses, it was not working for low doses. So we then had to add in multinomial logic models for these low doses, where we simplified what could then happen to going off the drugs, staying on the same dose, having an acceptable increase for both strategies, and having an acceptable increase for the higher target pain strategy only, or an unacceptable increase in both. And cutting again a rather long story very short, we resolved the problem of the higher weights. And I just wanted to make the general points that extreme weights often indicate a need to refine your specified treatment strategies. So, for example, your specified treatment strategy, this is just a general point, not specific to the hemoglobin, the current example. Suppose your specified treatment strategy is remain on your current treatment, and then you model the probability of remaining on your current treatment over time, and you find that the probability of a treatment change is close to 1 after a particular clinical event. In general, that may indicate that clinically it's mandated to change treatment after that event, and that your treatment strategy shouldn't be remain on current treatment, it should be remain on current treatment unless X occurs, in which case change current treatment. So extreme weights are a problem in estimating causal effects, but they may also indicate a need to refine the definition of the treatment strategies being compared. All of the agonies over specifying these weighting models are summarized in this paper here, published a couple of years ago in Epidemiology. And to briefly talk about the results, these are weighted survival curves and adjusted hazard ratios. So red is our more conservative target of 95 to 115. Blue is our more aggressive target of 105 to 125, and the adjusted hazard ratio was a bit lower for the more aggressive model. And in our results paper, not yet published, in green, we emulated an even more aggressive target of 125 to 145 and got a hazard ratio of 1.2. The truncating the weights, as you might expect, narrowed the confidence intervals, and the point estimates didn't change all that much. So that was reasonable evidence, I think, for the middle target being optimal in terms of all-cause mortality. What am I doing on time?
When you have used 25 minutes.
Well, I'll move on to our second example, which is clinical trials comparing multiple sclerosis treatment strategies. Work led by Cyrus Darawalla and Will Brown from the Cambridge Clinical Multiple Sclerosis Group, and with my colleague Paul Madley-Dowd from Bristol. So this is about multiple sclerosis, the most common cause, non-traumatic cause of disability in young adults. The pathology of it is central nervous system inflammation, demyelination and neurodegeneration. And it has these 3 stages: a pre-symptomatic stage, a relapsing remitting stage, which is what we're focusing on, and a secondary and progressive stage leading to clinical disability. It's one of the areas where there's been extraordinary progress with new drugs being introduced over the last 20, 30 years, many of the more modern drugs being expensive but more effective and less toxic drugs based on monoclonal antibodies. And these can be classified as the older drugs, which are called platform disease modifying therapies, moderate efficacy drugs, and then the more recent high efficacy drugs, often based on monoclonal antibodies. So platform, moderate efficacy, high efficacy. And we were interested in whether treatment escalation should be considered in response to breakthrough disease activity. And I'm not going to talk about further work on early high efficacy treatment. So patients with relapsing remitting multiple sclerosis will receive regular MRI scans. Lesions on MRI scans are often associated with relapsing and with worsening disability, but sometimes new lesions occur, as in this scan, a new lesion occurring between 21 and 23, and these lesions are called clinically silent if they're not associated with relapse or worsening disability. And these clinically silent lesions, or CSL, occur 5 to 10 times more frequently than clinical relapses. Current guidelines recommend escalating, which is going from platform to moderate or moderate to high efficacy disease-modifying therapies, only if multiple silent lesions are detected. And single silent lesions haven't been found to be associated with poor outcomes, although studies of that issue are small with limited follow-up. So we wanted to look at prognosis, are silent lesions associated with subsequent relapses and disability working, and management, what's the effect of escalating versus not escalating disease-modifying therapy after silent lesions. The analyses use this extraordinary MS-based neuroimmunology registry, 120,000 patients, 200 clinics, 45 countries. And very briefly, we are interested in patients with both a comparator and an index MRI in which a new silent lesion has been detected and who during the same period didn't change their disease-modifying therapy, didn't experience an increase in disability, and didn't experience a relapse. So that makes it a clinically silent lesion that occurred in the last 18 months. So this is the prognostic analysis, investigating whether a single silent lesion is associated with worse outcomes, not causal inference analysis. And our colleagues produced this very nice Kaplan-Meier with adjusted hazard ratios showing that the hazard ratio for relapse was about 1.95, comparing 2 or more clinically silent lesions with no clinically silent lesion, and 1.63 comparing one clinically silent lesion with no clinically silent lesion. And it took a while before I realised that this Kaplan-Meier is a weighted Kaplan-Meier. Now, you all know that one of the most elegant uses of inverse probability weighting is to weight the population according to is to weight Kaplan-Meiers to get the probability that the survival curves had everybody been treated versus survival curves had nobody been treated. Beautiful example of inverse probability weighting. Should be used often to in nothing to do with time variant component to illustrate causal effects over time. But here, this was being done for an exposure, clinically silent lesions. And eventually I said, I'm just not happy with this, because what you're imagining here is that you can hold all the other variables, all the confounding variables constant, while simply changing the presence of a silent lesion, and I just don't believe in it. And we eventually got to the point where I said, if you don't take it out of the paper, I'm going to withdraw on the grounds of it's offending against causal inference purity, and I only won the argument on that basis. Of course, the reason they loved this paper so much is that the crude hazard ratios weren't quite as impressive. So this was a really nice Kaplan-Meier making the point, but I don't think the basic message is you be careful about these wonderful techniques that we now have suddenly getting applied in causally questionable circumstances. The effect on confirmed disability worsening, which is really the event of interest, was less impressive than the effect on relapse. Here are the iterations that we made between the initial and final protocols. There were lots of changes to eligibility, related to having to be really careful about time periods when you think about target trial emulation. So it's not enough to say there was an MRI scan. It had to be MRI scan within the last 6 months of the baseline, and then 12 months previously doesn't work because things don't happen exactly 12 months previously. So between 6 and 18 months previously, and in analysing the data in initial analyses, then we realised that index MRI scans needed to be done after 2007 and after high efficacy drugs became available in that patient's centre. And so lots of changes to eligibility based on trying to implement the eligibility criteria and on further thought based on the initial analysis. Equally, so more importantly, I guess, we changed the interventions being compared. The initial protocol said that the escalation intervention was to escalate to a higher efficacy DMT, that's platform to moderate or moderate to high, and continue it throughout. Follow-up, the final protocol just said escalate to a higher efficacy disease-modifying therapy. And the reason for changing that relates to some of the discussion yesterday. If somebody escalates to a higher efficacy therapy and then comes off it, that's probably because they didn't tolerate it, and that's consistent with clinical practice. The original protocol said continue a lower efficacy DMT throughout follow-up. The final protocol said continue a lower efficacy DMT unless there's a clinical event, in which case you must escalate. And that was all based on, we find these stacked cumulative incidence plots very useful. Think about different events that can occur over time. And in particular, we realized that many patients were escalating, had relapses and then didn't escalate their DMTs. And we thought that if we included these events then in the control arm, then we'd be mimicking conservative treatment more generally. And finally, we planned to use the most robust disability milestone, which is an EDSS score 4, and couldn't do so because the incidence of that outcome was simply not great enough to allow it to be analysed. So this was an example of sequential emulation, because patients can be eligible to escalate but not escalate on multiple occasions. So this was 26 emulated trials starting at weekly intervals during 6 months between silent lesion, while taking 6 months after a silent lesion, taking platform or moderate efficacy BMT. Censoring on deviation from the treatment, the treatment strategy, and the results suggested substantially lower risk of cumulative incidence of relapse after escalation than after control, and that lower risk of relapse applied after a single clinically silent lesion as well as multiple clinically silent lesions. For disability worsening, no real evidence of benefit. So cumulative incidence similar in all participants. Cumulative incidence of disability worsening is actually slightly higher after DMT escalation in participants with a single lesion, slightly lower after multiple lesions. Now, as always, we go by first this recent paper. They'll probably write that on my tombstone. This nice paper talks about the impossibility of pre-specifying your whole target trial emulation protocol. So to conclude, emulating a clinically relevant target trial is inherently iterative, involving detailed discussions between clinicians and methodologists and exploratory data analyses, many of which inevitably involve looking at the outcome. I think stacked cumulative incidence plots, thinking about the different events and how they occur over time, are useful to understand the order in which events occur, refine intervention definitions, and look at feasibility studying different outcomes. Extreme treatment weights are a pain analytically, but may also help you to define intervention definitions. And in light of all this, and hopefully there'll be a bit of time for discussion, we need to consider best practice for target trial emulation. What aspects of protocols can be pre-specified, and how do we document changes transparently, given that these changes will be based on data analyses involving outcomes, something that's considered completely unacceptable in randomized trials? And what open science practices will help the inevitable possibility of data dredging and selection of the result that we like, rather than the result that is best in the more objective sense that we all aspire to. Thank you very much.
Sure, we have questions. And we'll see, Jessica,
Yeah, that's been great. I have sort of a high level question. What do you mean by target validation? Because I had a paper, for example, with some of those co-authors and Miguel on dynamic strategies for controlling sort of target EPO. And we used parametric P formula. And this was published in 2018. We probably started working on it long before that. This was before target trial, that term, like over to the world. And so I sort of look at what you have there, and I would have titled your paper. Basically, the title that we used was Comparing Effectiveness of Dynamic Anemia Strategies Using the Parametric Template. So I think you could title that paper Comparative Effectiveness of Dynamic Anemia Strategies Using Inverse Probability of Censoring Weighting. Because there's also now in 2026, like we could use double bias estimators for those same strategies. So I think I'm just making a just sort of, I think it is important to understand what that term means, because there's sort of decades now of literature on where a target trial protocol comes from. It comes from all of that literature on causal inference. So I guess I just wanted to understand, like, does target trial emulation probably like clone sensor weighting, or does it mean something broader? And so is there sort of value in being like that way?
Thank you. Luckily I'd forgotten what a scary audience this was to really talk to.
This is not, by the way, an attack on you. I think this is like, I'm sorry about this. I think it's just useful in this venue to just sort of throw this into the universe.
So if I think about, if I can go backwards, think about the history of how I got into this, which was applying marginal structural model in HIV more than 20 years ago. I got into it very interested in this technique and less clear about what was the question being addressed. If you look back to the paper we published in The Lancet in 2005, we kind of tried to, we used an analogy with randomized trials and sequential randomization over time, but there wasn't a clear specification of eligibility at a fixed time point. So I think that target trial emulation, the essence of it for me is being really, really clear by reference to what a randomized trial would look like on who is eligible, and among eligible people, what are the strategies being compared. There's nothing super fancy about it. There's no specific method that is mandated if you are emulating a target trial. But I think there are lots of papers that kind of say that they're implementing a method such as G computation or marginal structural models, where there isn't a clear statement of eligibility, and therefore the causal contrast isn't clear. And I guess the other more methodological aspect to it is that if you think like that, there then follows a strong focus on time zero and aligning eligibility, assignment to treatments, and start of follow-up. And it then becomes easier to plot cumulative incidents, as you would in any primary report of a randomized trial, and to avoid problems such as immortal time bombs.
Let's go to, is your question still standing, Max?
Yeah, maybe so. What do you think about the difficult in settings? Because there seems to be a lot of double dipping involved here. Do you believe your confidence is overall?
Well, I'm not sure I said the premise in that I'm not, when I talked about open science practices, I was trying to say, yeah, we need to be very explicit about avoiding double dipping, avoiding data fetching. But the iterative process isn't based on that. It's, well, a high quality iterative process will be based on establishing feasibility or realizing that the specification of the intervention strategies being compared needs to be refined, as in both of the examples I gave. And that's not the same thing as just double dipping to produce the result that you want. But I don't think we have the practices established to help enforce that.
Right, so then if you go back to your plot where you showed the nice plot where you showed the cumulative incidence curves with different colors, then it seems like you looked at some cumulative incidence curves, then updated your analysis and you get Causal. So in the sense that you look at your data and you see that the weights are big or extreme, or you look at your data, the confidences are too wide for this particular strategy, and then you implement the new one. That is already dredging, but not with this malignant intention.
Well, I think dredging implies malignant. I suppose I've provoked the discussion that I wanted to provoke because it is certainly looking at the outcomes and making changes to your analysis.
That invalidates inference. The statistically invalidates inference.
Well, it would if you. Okay. Let's say the simplest example of finding out that you can't use a particular outcome because it doesn't occur sufficiently frequently.
Yeah.
I'm not convinced that invalidates the inference for the outcome that you can analyze, for example.
It is a post-selection problem because you're selecting based on variables that are associated with one using the final analysis. There are certain things you can do, and that needs to be anterior statistics, such as you could choose them based on the propensity scores only. I don't think this is a problem. This is a problem that you mentioned by Miguel there, and I can contextualize it.
Right.
I think it's like a broader problem. The whole idea if you give up doing inference based on pre-specified criteria, you're giving up the guarantees.
Maybe this is going to come back in the debate. I can see we have another couple of.
It's an important list.
Let's go to Nan first and then one at the back.
Yeah, related very much is data splitting an answer. So would you say I give up my sample size, I use half to really do the iterative process, get the best estimate for the procedure, and then blind myself for the rest of the data and then get my estimate then?
Well, it would be if you had access to huge data set, potentially.
Well, the way I've worked with Miguel is down because I agree in the sense that how do people do trials? They run a phase 1 trial or a pilot, and what do they opt? The pilot, they update their protocol. So if you had separated out some data and done everything on that split, then you can mimic actually the process as well. Because they didn't come up with a protocol, they didn't get like a revelation from God, right? They did a lot of analysis in the basic sciences and on separate data sets. And you can mimic the whole process, but you throw away data, and Miguel doesn't want to do that. So, at some point you have to, and you cannot do cross-validation, because you define one, it needs to be a chemical order of events. But anyway, we can discuss that.
I see, let's go to your question back and then to the next set, and then we can have to.
So my question is, for making causal inference, randomized trial is the gold standard. But here, in clinical trial, we will do randomization to make two group balance with respect to known and unknown confounding. So here in clinical trial, here target trial regulations, we do the such things randomization by some prospective stage score matching or some other method. So can we say that this is the most important to take care of both the group balance with respect to known and unknown confounder as well? And this is essential in target trial regulation for species score matching or other things. Such procedures.
One of the pitfalls of giving presentations like this is that there's an underlying truth which I didn't emphasize, but it's still the underlying truth. The underlying truth is that any inference here depends on a strong and potential and possibly implausible assumption of no unmeasured confounding. So how you control the confounding depends on whether it's baseline confounding, in which case you might use a propensity score or conditional baseline covariance, or using the probability weighting, or if it's time varying confounding, then you can't condition and you might use the G formula. But all of this, I'm sure this group understands, how you control confounding doesn't matter, but it's always based on an assumption of no unmeasured confounding, which I guess will be violated. The question is how seriously will be violated. I guess I kind of, my whole talk assumed that without stating it, but it's always true.
Vanessa, last question.
Yeah, so I want to return to the question with the data, but I had the impression that a lot of what you did didn't really involve the outcome. You can look at the weights, whether that doesn't involve the outcome and whether you have extreme weights. So what we do when we use the claims data is we do very detailed drug utilization studies before we don't look at outcomes, just about that, or over time, etc. And that none of this, it informs a lot the target trials that we could use. And I was wondering whether so I liked your table where you said initial target trial and then actual target trial and reasons for change that communicates it clearly, and you could kind of say, well, this part only involves treatment and covariates, and certain parts, and you highlight those to at least make it transparent, which would be the first step, involve the outcome.
Right. So I agree. There will be certain changes that can be made without knowledge of the outcome, and one can document those. But I think we're all kind of agreeing that there will then be there are then likely to be further refinements to your target trial that do involve looking at the outcome, and then the question is how much of a threat to inference are those changes based on outcomes, and what are appropriate practices to deal with it. There's certainly some of the changes can be done simply based on modelling the probability of treatment, for example.
Thank you very much.